Research funding challenges. One of the issues that I've observed in different countries is that often funding for this work comes up. It gets funded for 5 years because it's someone's favorite thing, and then it goes away again. And I think this is a fundamental challenge to healthcare systems, and we're going to have the same problems or different problems, but similar problems in 10 years' time. And we need to argue that actually we need a fairly consistent funding stream to support this, to actually ensure that we're getting appropriate translation of knowledge as we move forward. The fact that the NIH now has a standing panel for dissemination and implementation research, I think is really important globally, because a funder like NIH is sort of making a more sustained commitment to the field. The final challenge is the DI squared challenge. And the idea here, is that the research that is being done, the dissemination and implementation research that's being done, could and should contribute to more effective dissemination and implementation research, dissemination and implementation activities in service settings. Okay? But the findings of this research is not going to change implementation activities in healthcare settings unless people in healthcare settings adopt the ideas coming through. And I think at the moment, we do a very bad job at understanding who are the kind of receptor sites for the work that we're generating in service settings. Who should we be trying to target and influence, as if we do get ideas about how to try and improve implementation quality of care, hopefully they can then pick up the flame and run with it in their healthcare setting. So I think we need to spend a lot more time thinking about who are our receptor sites and how do we actually influence them. Oh, I have 7 seconds left and I have 5 slides left. I'm going to just keep going if that's okay. I'll try and move through this quite quickly. The final slides relate to developing the field of implementation science. And this is again about how do we organize the area. Most implementation science is done on a project-by-project basis. You have a question, you pull a team together, you develop, you conduct the study, you hopefully publish the study, and then the team disappears, and you move on to the next problem that you've got, or the next issue you want to deal with. And I think there are many issues related to that. We really fail to build capacity within teams. We fail to learn maximally from project to project, because we often lose, if you like, the team knowledge by the dispersion once the team is over. So I think we need to move into what I'm calling implementation research laboratories, but have research teams that are integrated into the healthcare system, undertaking research programs that are directly relevant to their healthcare system's priorities. And if we could do that, so you embedded this and you actually had a much more sort of engaged process where the researchers were working with the healthcare system on problem identification, thinking about what the barriers are, thinking about what the solutions are, and then with the will of the healthcare system being able to evaluate those, then we could generate, I think, a very exciting science. It reduces the problems relating to convening a de novo research team, seeking project-by-project funding, negotiating access with the healthcare system, conducting the study, and also writing up. I think the other thing it does is it really facilitates the kind of sharing of tacit knowledge in both the service setting and in the research team setting. And people build relationships that I think really sort of feed off each other. It also makes more explicitly recognize the relative roles of the research team in the healthcare system. It's our job to help build an intervention and evaluate it. It's a healthcare system's job to have to actually deliver this. So it's not that the researcher delivers this and as soon as the research team goes away, basically the healthcare system's lost that information. Here's an example of an implementation laboratory where, alongside a national guidance program for dental community dentists in Scotland, we actually have a translation research program. And this is a really nice description of how those things might marry together. We need to think about, unfortunately I won't be here for the second last talk, we need to think about how we build or capacity in the research field. What are the core competencies that we need to try and address and get across? How do we deliver those within graduate programs? How do we build careers for people who want to then take this on as being part of their lives? We have there's an increasing number of places we can publish. So Implementation Science is an open access journal that was actually a joint initiative from European researchers and particularly people in the VA in the US, but now a broad range of the community. And it was partly to try and create a space where early things could be presented. Stuff that major journals would not be interested in, but one place where as a community we could actually talk about the issues that we've got, and you'll have seen a lot of the things I've presented were actually published in this journal. One of the things that we're currently discussing amongst a number of people is, do we need to formalize the field? At the moment, the field is almost like a boundary spanner, living across a quality improvement, implementation science, knowledge translation, other sort of fields. And the real benefits of being a boundary spanner, you can bring people in, you can help transfer of ideas across different groups and communities. But it may be time to say we actually need to think about formalizing the field and developing what I would call an international society for implementation research. And the reason being that I think we need to sort of have somebody that can start to sort of articulate the value of this on a global level, can start to think about what are the core curriculum and career structures, can start to provide a focus point where people can come and actually discuss the work that we do. So this conference today is a relatively unusual conference globally. There are lots of conferences you go to where implementation stuff is discussed. There are very few that are devoted specifically to implementation. And actually having a venue where we can actually talk through what we want to talk through rather than always having to explain what implementation science is might be kind of useful. So there's an ongoing debate and would be very interested in if anyone's interested in that, in sort of contacting me. So summary, implementation research is about saving lives, improving health outcomes, and the quality of health services. We should feel very passionate about this. There's a substantive evidence base on the effects of different interventions, and the good news is that it is possible to change stakeholder decisions and behaviors. When I started working in the field, there had been editorials published in The Lancet and the BMJ saying, you can't change clinician behavior, you can't improve quality, all we can hope is they retire or die. We have a lot of evidence that we can do this. But at the moment, it's probably not as valuable to the healthcare system because it's not as practicable at this point in time. And there's a real issue about, as I said, translating this knowledge to make it useful for healthcare systems. And I think there's lots of opportunities for future research, and delighted that people in this audience are interested in this and presumably going to contribute to the evidence base that we've been talking about. So that's my email, and then also just a couple of URLs. So thank you very much.